The development of the fetal cortex and the formation of the sulci and gyri is an orderly but overlapping process with well-defined milestones. This process includes, first, the proliferation of the neurons and the glial cells in the germinal matrix, which is periventricular, and then migration from the periventricular zone to the cortex and organization of the neurons of the cortex. Any disturbance during this time produces a wide range of cortical malformations that may cause neurological deficits and/or seizures. The malformations can be due to genetic factors, which are now being elucidated very quickly in the era of the exomics, and it can be due to prenatal injury like trauma, infection, or teratogens.
When we speak about the prenatal detection, okay, we start from screening studies, and you should look for specific signs that may help you in the diagnosis, at least in the suspicion of a malformation of cortical development. So we look especially at patients that have a small head, big head macrocephaly. Every patient with a ventriculomegaly, even if it's mild, patients that have an abnormal midline, because we know very well that pathologies of the midline goes with malformation of cortical development in a huge amount of cases. We look also for asymmetry of the brain structures, and we look for echogenic or hypoechogenic lesions in the brain. But eventually, malformations of cortical development are rarely diagnosed in our practices. When you look at the brain, and you are performing now, something is wrong, and you are now performing a detailed neurosonographic examination, there are some signs that may help you in at least make a suspicion of a malformation of cortical development. And the first thing I am showing here is when you have the presence of abnormal, early developing sulci. Okay? You have a fetus at 22 weeks that should be lissencephalic, but instead you have here the presence of sulci, or when you have a very smooth cortex later on in pregnancy. Okay, this is for comparison how it should look a normal brain at 22 and 28 weeks. At 22 weeks, the brain is lissencephalic. At 28 weeks, you should see the presence of sulci and gyri. Other thing, if you see that the sulci are very broad and very profound, okay, those are sulci that are there, but they are abnormal. There's a lot of fluid in between, or when you have a very small, smooth, and thin cortex. Upper to the arrows, what you see here, there is the CSF. Again, you should look always at the shape and form of the lateral ventricle. This is an extreme case, but it's very, very early diagnosed, where you see that the shape of the lateral ventricle is absolutely abnormal because there are bumps and indentations, okay? Or an irregular cortex. The cortex should be, again, very, very regular, and here you have an irregular cortex. This is an early sign of possible polymicrogyria. Another thing that you should look is a very symmetric brain. If the shape of the brain is very symmetric and the operculi are not developed, there's a lot of fluid around the brain, you should think about the possibility of lissencephaly. Other pathologies, when you see a continuation between the subarachnoid space, extraaxial space, and the lateral ventricles, the presence of nodules, of cortical nodules, the presence of subtle anomalies of the corpus callosum. You see here corpus callosum, okay, this apparently is normal, but here something happened, and the same place that the corpus callosum is bumped, there is a finding, and this finding may raise at least the suspicion of a pathology, a focal pathology in this place, or again the presence of periventricular nodules. And look, it's very, very early, even before the time that you can perform an MR, and you can say this patient has periventricular nodules, probably periventricular nodular heterotopia.
We'll not discuss malformations due to abnormal proliferation or apoptosis in this lecture. We'll go into it on the lecture on micro and macrocephaly. So we will discuss malformations due to abnormal neuronal migration and malformations due to abnormal cortical organization. So this is a demonstration of, we used to have, when we talk about malformations of cortical development, we used to divide it into lissencephaly type 1. Lissencephaly type 1, which is lissencephaly and subcortical band heterotopia. And we used to talk about lissencephaly type 2, but since the elucidation of the genetic mechanisms, we no longer call it lissencephaly, but now we call it cobblestone complex or cobblestone malformation, and we talk about heterotopia. So here we can see what the normal cortex should look like, and here we can see lissencephaly type 1, where the cortex is smooth, and here we see the cobblestone appearance, and the cobblestone, if you look, it looks smooth, but inside this smoothness, there's all these irregularities. So this is cobblestone, and what is associated with cobblestone is the enlargement of the ventricles compared to lissencephaly, where the frontal horns are usually not enlarged, but we can see colpocephaly. And so this is a very big difference, even though if you look at the shape of the operculum, it looks the same or even worse here. And here we look at heterotopia that are paraventricular and protruding into the ventricles. So this is a classification. Our guru of pediatric neurology is James Barkovitz, who was already mentioned earlier. And all the classifications of the brain malformations, there's a classification from 2005 and a new classification for 2012. And the classification has changed tremendously, and no one can ever remember it anymore because new genes are being found. And as we find new genes, we find that different brain malformations can be related to the same gene. So it's no longer easy to say this gene causes lissencephaly because the same gene can cause different diseases. But this is a more simplified classification, even though it doesn't look like it. So we talk about the LIS1 mutations, the DCX mutations, ARX, which is an X-linked disorder. This is the X-linked dominant disorder. And then we go on and talk about other genes and if they're associated or not associated with agenesis of corpus callosum or with cerebellar hypoplasia. And we try to elucidate, we look for the genes based on our pattern recognition. So pattern recognition is a very important word in pediatric neurology, and I would like to convince you that it's also important in fetal neurology. So here is the classical lissencephalic brain, and it's a migration anomaly, and the result is the smooth brain. And we know already 7 genes that cause this, and these are the most interesting genes. We'll go into them in a little bit of detail later on, because here, this was the first gene that was discovered, and then the second one. And now, in the last 2 years, this gene was first described as a gene of lissencephaly, but now it's already known that more frequently it causes polymicrogyria. So this is the most severe of the migrational anomalies, and affected individuals are profoundly mentally retarded and usually have severe seizure disorders. The seizures are intractable, and all the medications, there's no medication that is very good in treating them. They're considered, the major problem is in the GABA neurons, and we try to enhance GABAergic transmission with certain drugs, but it really doesn't work. And so the migration abnormality is early in pregnancy. It occurs between the 11 to 26 weeks, and the result is an abnormally thickened cortex, and sulcation is largely absent. This is very important to look at, because here we know the cortex is thickened. Because when we see a smooth brain, but the cortex is not thickened, we have to think about other etiologies and not about lissencephaly. And there is no 6 cell layers. Instead, there's usually 2 to 4. But there are layers. It's not absolutely lack of layers. There are 2 to 4 layers. And colpocephaly is usually present. So these are the genes, and as you can see here, the interesting thing is what the gene function is. What these genes do are they're associated, most of them are associated to the microtubules. And the microtubules are important in the neurons because they help them radiate on the radial glia. And they move by contracting. And the contraction is, the microtubules are very important in order to let them contract. And when we have abnormality in microtubule-associated proteins, then we have a problem with migration, and the result is these disorders. This is a very interesting gene because it's only in charge of migration of GABAergic interneurons, and it causes very different disorders. It can cause lissencephaly with agenesis of corpus callosum and ambiguous genitalia, but it can also cause just excellent mental retardation with no malformation at all. And it can also cause disorders of movement, like Partington syndrome, where you don't have to have a brain malformation, but you have a severe mental retardation and dystonia. So this is also very important. Lissencephaly is not just this, where we don't have gyri at all and we have a completely smooth brain. We have decreasing severity, and our grading system is based from 1 to 6. And as we go on, you see that there is gyration, especially frontal, and not in the back. And the higher grades, next. The higher grades are, this is a higher grade. What we see here is a band heterotopia. So initially we thought that DCX, which is also called double cortine, the protein is called double cortine, causes in males, it causes a lissencephalic brain. But in females, it causes a double cortex. So we knew that from the discovery of the gene. But now we also know that even LIS1 can cause, and this is a dominant inherited disorder, or usually most of the cases are sporadic. Here we can see the double cortex. So you can see a double cortex in both cases, not just in DCX, but also in LIS1. So the grading is important. This is a child with Miller-Dicker syndrome. Miller-Dicker syndrome is a deletion on chromosome 17 where the LIS1 gene is, but other genes too. So we can see also dysmorphic features and other abnormalities. This is a CT. You can see the severe abnormality of the brain also on CT. And of course here you see the gradient. And as you see, there's a posterior to anterior gradient. The posterior is more severely involved than the anterior. This is a very important clue, because it's the other way around in double cortine. So we know here that this patient will have LIS1 mutation or deletion compared to a child with a DCX. So here you can see the characteristic facial appearance. This is very characteristic when we see a baby, a newborn, that has this furring of right here. We know that the child will have a lissencephalic brain underneath, and also they have narrowing of the temporal areas. They have a very small nose, and they also have profound mental retardation, feeding problems, seizures, recurrent pneumonia, and they have a shortened lifespan. And you should always look for associated anomalies like heart defects and other organ involvements like the kidney. And it's important to remember that this, if you have other organ involvement, this will not be a LIS1 mutation, but it will be a LIS1 deletion. And the deletion, the Miller-Dicker spectrum, we can diagnose by doing CGH, or you can do FISH specifically for that area. So we know there's a genotype phenotype correlation in the lissencephalies, and so the gradient is very, very important. Next. Mutations of DCX can cause, as I said before, the subcortical band heterotopia or X-linked lissencephaly. And this is a patient of mine, and this is her brain. So you see she's a very cute, good-looking child, and she only has mild mental retardation. She learns in a regular school, but in a special ed class. And when the radiologist saw this severe abnormal MRI, you can see she has a very, very thick band surrounding the ventricles. There's very little white matter, and you see the cortex is very, very thin. So when the radiologist saw this MRI, she came up to the parents and she said, "Your child is probably very, very retarded." And then she saw the girl as she was waking up, and she was very surprised. So these girls have, they can have normal intelligence or mild mental retardation, but their major problem is seizures, and currently she has intractable seizures. She wakes up every morning in status epilepticus. That takes about an hour until she comes out of it, and no medication has helped her up till now. In males, it's much easier because all males with X-linked lissencephaly with double cortex have severe mental retardation and epilepsy and a limited life expectancy. This is a specific mutation, and you can see this is a male, and you can see the same mutation in a girl will lead to what we saw before, double cortex. The same mutation in a boy may lead to lissencephaly type 1. The 2x1A story, this is very, very interesting. So what we know is it's a rare cause of classical lissencephaly, only about 1% of the cases. The same kind of gradient, posterior more than anterior, which we see in LIS1 mutations. And in 30% of the cases, we also have cerebellar hypoplasia, which before we thought was only related to mutations in renin. And it's also a rare cause of atypical lissencephaly with abnormal basal ganglia, abnormal corpus callosum, and polymicrogyria. But it can also cause cerebral hypoplasia without lissencephaly. And what we're learning now, there's a large field which is called tubulinopathies, and tuba-A1A is just one of them, and other malformation, other tuba mutations can cause Mebius syndrome and can cause abnormalities only of the brainstem and non-development of different structures of the brainstem, resulting in either like a severe disease with eye movement problems, swallowing problems, facial movement abnormalities like Mebius, or a less severe syndrome, which is Duane syndrome, which we only have eye movement abnormalities. So this is a very important flow sheet, which was suggested by Cato and Dobbins. And so what you need to do is, if you want to understand, this is based on MRI, but I think that at least part of it can be done also by using ultrasound. And first of all, you have to grade the abnormality. Is it severe with no gyration at all? Or is there gyration? Or is there a double cortex? This is 5 to 6. I've never seen double cortex identified in utero. Have you? So the next phase is we have to look at the gradient, okay? In order to decide what gene we're interested in, we have to see, this is seeing the patient, of course. Does he have dysmorphism? What you can do is you can do a 3-dimensional ultrasound and see if the nose is very small. Maybe there is bitemporal narrowing that you can see low BPD. And if there is dysmorphism, and are there associated abnormalities? If there is, it's going to be LIS1 plus 14.3.3 epsilon, which is Miller-Dieker syndrome. If there's no dysmorphism, then we should think about double cortine, because there's no gradient here.
Okay, now what about the ultrasound? Okay, the ultrasound of Miller-Dieker, the diagnosis of Miller-Dieker is difficult. It's difficult because those fetuses usually don't have severe ventriculomegalia. This is a case, a medical legal case. I make the defense that the patient was seen at 22 and 27 weeks, and always they measured the lateral ventricle. The lateral ventricle was all around the pregnancy between 9 and 10 millimeters. Never goes more than 10 millimeters. But if you look at the sylvian fissure, you see that at 22 weeks the sylvian fissure is not developed, and at 27 weeks the sylvian fissure and the parieto-occipital fissures are not there or are very undeveloped, and the diagnosis is made not based on the width of the lateral ventricle, but due to the presence of abnormal sulcation. This is how Miller-Dieker looks by fetal MR. And again, what is very, very important, and I learned that from Daniela prior, is that in those fetus of the Miller-Dieker with lissencephalia, the hemispheres are very, very symmetric. again, there is not marked ventriculomegalia, but there is no sulci all around the brain with a very undeveloped Sylvian fissure.
So the next part after we look for the dysmorphism is to look at the gradient. And if it's anterior to posterior, it's less frequent. And then we look at cortical thickness. This is by MRI. I don't know how, is it possible to do it by ultrasound?
I hope I show the cortex. We don't measure the cortex, but you can differentiate between a broad cortex and a thin cortex.
So this is very important in postnatal MRI because we know that in classical lissencephaly type 1, the cortex should be above 10 millimeters. And if it's, you can see that this will be a double cortine mutation if there's anterior to posterior gradient and the cortex is thick. If the cortex is not thick, it will not be a double cortine mutation. Then you have to look at cerebellar hypoplasia. If we do have cerebellar hypoplasia, then we can have Relin, VLDLR, and 2/A1A, even though usually it will have a different gradient. The gradient will be posterior to anterior. But 2/A1A can do everything, so we should remember it even in this part. So then we look at the gradient, and if it's more posterior than anterior, again, look at the thickness, and if it's above 10 millimeter, it's going to be LIS1 or a LIS1 deletion. If it's under 10 millimeter, look for ACC. If you do have agenesis of the corpus callosum, the most frequent one will be ARX mutation, but also 2/A1A plays a factor here. And there are other genes that we haven't found yet, and we don't know about them.
Okay. Again, here is a patient that we knew that there was cerebellar hypoplasia. The lateral ventricles at 17 weeks were quite prominent, particularly the frontal horns, but look at 17 weeks, the Sylvian fissure is inexistent, and at 22 weeks, again, is inexistent. The brain looks very, very symmetric, and the cortex is very thick in comparison with the lateral ventricles without Sylvian fissures. Now, it's particularly difficult when you look at these images to know, is this a normal or abnormal sulcation? And again, what I used to do, okay, is to take this image and to put it close to one with normal sulcation at 22 weeks, so you can differentiate quite well that something is wrong with the fetus in the left side. And this is due to the lissencephaly. There are cases with lissencephaly and cerebellar hypoplasia, but with a very thin cortex, okay, that we prove the lissencephaly also pathologically. You see that the cortex is absolutely unlayered. This is a case of classical lissencephaly with agenesis of the corpus callosum, 33 weeks, also by ultrasound and also by MR. Okay? This is an ultrasound, this is an MR, but you see more or less the same thing. You see that there is absolutely no sulcation, moderate ventriculomegalia, agenesis of the corpus callosum. Another case of fetus with autosomal recessive lissencephaly. There's a consanguineous family, and the corpus callosum is very dysplastic with a normal cavum septum pellucum, a little bit large cavum septum pellucum, almost no ventriculomegaly, but absence of the corpus callosum, and also with a very small cerebellum.
So the last part of the evaluation is when we see the grade is only 5-6, and the form of the brain can look normal, or the cortical thickness may be smaller because there's a band underneath. And again, we look, where is the band? Is it anterior more than posterior, or again, posterior more than anterior? And we can make the diagnosis if it's DCX or LIS1. We will continue with cobblestone complex. So here, this is a very interesting group of disorders that are due to abnormal O-dystroglycans, and it's O-glycosylation. We now know there's disorders, we have glycoproteins, and the glycoproteins are glycosylated by residues that are mannose, like mannose, sialic acid. And if we have abnormal glycosylation, we have abnormal function of the dystroglycans. And when we have abnormal function of the dystroglycans, we will have a cobblestone malformation, usually associated with a muscular dystrophy and also eye abnormalities. So the cobblestone cortex is it's no longer just cobblestone cortex, but a complex, because it includes both the cerebral cortex, but also the cerebellar cortex. And we can see cysts in the cerebellum, which are very typical of this abnormality. And it also has a pebbled surface, not just the cortex, the cerebral cortex. We have areas that look smooth, but we have areas that look like there's more than we should have gyri. So they look like polymicrogyria, they look like pachygyria, but they are cobblestone. And we have a thick fibroglial rind over the cortical surface that often obstructs the subarachnoid space. This is very important in the understanding of how this malformation develops. And interestingly, there's also an abnormal white matter and patchy or diffuse dysmyelination. Very interestingly, the severe white matter abnormality is seen in the first year of life, but then as we go along and do other MRIs, it goes away. And what we see here is we see enlarged ventricles. Usually we have hydrocephalus. And there's also associated hypoplasia of the brainstem. And the brainstem looks very abnormal with a Z shape, which is typical for this disorder. There's also cerebellar hypoplasia. And in some of the syndromes, like Walker-Warburg, we can have occipital cephaloceles. And we can have absent septum pellucidum, usually because of disruption, because of the hydrocephalus, and an absent corpus callosum. Clinically, the children have abnormal eyes, and they have either microphthalmia or buphtalmos because of congenital glaucoma. And they have anterior chamber abnormalities, very different ones. They can have a cataract, Peters anomaly, or megalocornea. They have also retinal malformations, and they can have a coloboma and persistent hyperplastic primary vitreous. So the ocular findings are quite variable. And this is an explanation why we have a problem that involves both the brain and the muscle. So here, this is an explanation why abnormal dystroglycan causes congenital muscular dystrophy. So the dystroglycan is associated to dystrophin. You see it's part of the dystrophin-associated glycoproteins. And here you can see the dystrophin inside the membrane, and here is the dystroglycan. And what we know now is if the dystroglycan is abnormal, then we have abnormal linkage and binding to laminin, which goes into the extracellular matrix, and we have disruption of the membrane of the muscle and causes a muscular dystrophy with abnormal CPK and severe weakness. Here is, I think it's even more interesting to understand the mechanism that causes the cobblestone cortex. So here we see that dystroglycan has an important, is very important in the marginal zone, which is above the cortical plane. And what we now know that the dystroglycan is important for the glia limitans. You see, if we do not have this connection between the laminin and the dystroglycan, there is a disruption of the glia limitans, and as a result, as the neurons, this is the radial glia, and this is a neuron that's migrating. As the neuron migrates, it continues to migrate into these holes, and when it migrates into these holes, you see the cobblestone appearance because we have these bumps that develop here. So really, the abnormality is not an abnormality of migration. That's why it's no longer called lissencephaly, but it is abnormality of the pia membrane. And there's no limitation of migration. Migration continues when it's supposed to stop. So these are the genes that we know now. And this is taken from an article from 2004, but this gene has been discovered this year as a cause of an alpha-dystroglycanopathy. Before, it was a cause of a different disorder that will be mentioned in a future lecture today. And here we can see the genes as they were discovered. This is fukutin, which causes what we know is called Fukuyama congenital muscular dystrophy. This is muscle iron brain disease, and which is mostly seen in Finland, and Walker-Warburg syndrome. And all of these diseases cause abnormal glycosylation of the dystroglycan. This is the alpha dystroglycan, and we can see where they function and what residue is not connected to the glycoprotein.
Tali show you these images previously. We have not hundreds of Walker-Warburg, so we show always the same images. But again, what you should look is at the presence of quite more profound ventriculomegalia and the S-shape brainstem. Again, the Z-shaped brainstem is quite clear in this MR in a fetus with very severe ventriculomegalia. This is the postnatal of the same fetus. And look here, what we call this cobblestone is because of this pattern that is like the cobblestone in the roads, okay, the bumpy cortex.
This, of course, is a child with Walker-Warburg syndrome, and you can see the dysmorphism, and you can see the abnormal eye, and of course you can see the brain. And when you look, when it's not high resolution, then you don't appreciate the pebbling, and you look at it and it looks like a lissencephalic brain. But this is very important to see that this cortex is not actually smooth.
And here is another case with a very, very thin cortex, abnormal congenicity of the cortex, a very small corpus callosum. The brain actually is completely atrophic and floating inside the subarachnoid fluid. Okay, and when you look at the pathology, what is important? Okay, there is lissencephaly. The cortex is not in layers, but what the diagnosis is made here when you see that there are full of neuroblasts that go through the pia and enter the leptomeninges and are positioned between the glia and the subarachnoid space. In this particular case, there was also muscular dystrophy. The muscle fibers were not regular, were different shape and size, and our pathologists found also the presence of retinal dysplasia.
It's very important also, as I told you before, in lissencephaly type 1, we have 4 layers of the cortex, 2 to 4 layers, and in cobblestone, we do not have layers. So it's also a way to differentiate them. The next subject will be heterotopia. And when we look at heterotopia, we define different kinds. So we can have subependymal or periventricular heterotopia. The most frequent and most well-known are due to Philomena A mutations. And, but we also have PNH with the mutations on chromosome 5, or with both associated with polymicrogyria and perisylvian posterior type, which is pathognomonic for this type. And we can have also periventricular linear heterotopia, which are very interesting. They don't bulge into the ventricle, they just surround it. And we can have subcortical heterotopia, not the ones that we saw before, because that is included in the classification in the lissencephaly spectrum. But we have subcortical heterotopia, we have large subcortical, and we can have smaller nodules. They can be only subcortical or other areas, and very different kinds.
Okay. This is an extreme case that was diagnosed at 40 weeks. The patient was referred at 40 weeks because of the presence of a large arachnoid cyst. Okay? And as we told you before, and we'll hear later, arachnoid cysts usually are benign. But what we realized is that the lateral ventricles were very asymmetric, and they were in one of the hemispheres there was pachygyria. The cortex was not well developed here, and there were bumps of the lateral ventricles. The lateral ventricles were not regular, and you can see here that there is normal sulcation, and here the sulcation is not visualized, and the same place there are bumps inside the lateral ventricle. And actually, we showed that also on the MR, and even the patient decided to go to ask for an abortion at 40 weeks, and we performed the abortion. This is the pathological specimen showing the correlation between the MR and the pathological specimen. You see very clear that here this hemispheric pachygyria with bumps of heterotopia, and again, the disease was there, but this disease was not relevant. With time, we have seen more and more cases, and I also have been described of cases of association between arachnoid cyst or large posterior fossa and heterotopia. So if you see a patient with a megacisterna magna or with arachnoid cyst, don't look at the arachnoid cyst, don't look at the cyst, go and look at the brain to see some of this kind of malformation that are much more severe. And this is another case. A patient was referred at 31 weeks and a half because of mild asymmetric ventriculomegalia, but actually the problem was here, the presence of the bumps. Okay, this is a case of periventricular nodular heterotopia. Another case, I show you the image, is a case that, again, we saw the heterotopia very early in pregnancy. It takes time until we decide that actually there was something abnormal. Okay, but here you see the bumps, okay? And we wait until 21 weeks to decide what to do with the patient. And what you see at 22 weeks is the classical shape of the lateral ventricle with bumps, okay, not regular walls. The corpus callosum was in this case normal. Okay, we see the asymmetric ventricles, and you look at these images are very, very similar to the images we saw at 40 weeks in our previous case. This is another case of a multifocal PMG with subcortical heterotopia. I can tell you for sure that we did not make the diagnosis by ultrasound. We saw there was against the corpus callosum, a very abnormal sulcation, abnormal cerebellum. The patient decided to go for an abortion, and the diagnosis was made in the pathological specimen that also have very severe skeletal dysplasia, nuchal thickness, okay, severe complex malformation. And here you have a very nice example of what is heterotopia. Heterotopia is the presence of neurons in a place where they should not be. In this case, the neurons here are in the white matter, are subcortical. Okay, and another thing I would like to show is the presence of the polymicrogyria. You see something that looks like a gyre, but is not covered by meninges. Okay, in a normal gyrus, the meninges go in. Here, there is no meninges, the meninges stop here. This is polymicrogyria.
Okay, I'm sorry, I'm going to say one more thing about heterotopia. The knowledge that we have from last year, from 2013. We now know that the reason for the paraventricular nodular heterotopia in filamine mutations, or another gene which is called ARF-JEF2, is that there is denudation of the ependyma. So the same mechanism that we have in heterotopia in the cobblestone complex is the same, causes paraventricular heterotopia because the lining of the ventricle is abnormal. So the migration, the problem is not in the migration itself, but the neurons are stuck inside the ventricles. So that's important to know. And we'll go quickly to malformations due to abnormal cortical organization. So as you see, there's a very long list, but luckily only few genes. And this has changed since this classification from 2005, GPR56, which was considered an abnormal organization because we now know the function of the gene, then it's no longer considered part of this classification, but it's part of the cobblestone complex. So we can have polymicrogyria. Polymicrogyria is probably the most complicated because it can be bilateral and symmetric. And when it's bilateral, it can involve the frontal lobes, or it can involve the parieto-occipital lobes, it can involve different areas of the brain. It can be asymmetric. It can line a cleft, and then it's schizencephaly. And then, or it can go with other brain malformations, or be part of a syndrome. So we see excessive number of small convolutions on the surface of the brain, and it can be diffuse or focal. It's merely a descriptive term, and it's not a disease, and it does not describe the underlying etiology or its cause, because it can be due to disruption or other causes. Go back, please, to the picture. No, to the MRI, the MRI showing the different forms. This is very important. Okay. This is very, very important because, as you see, You see, the polymicrogyria can look differently. So you can see how it looks here, here. The cortex can be thin or it can be thick. It can be the most important sign for ultrasonographers or radiologists is really this large space, the large subarachnoid space, because over the abnormal cortex, we have this large space and usually an indentation. So it's very important, as you can see it. And you can see there's different areas. This is also typical. You have to look at this. You can see there's a connection between the Sylvian, usually between the Sylvian fissure and the Rolandic fissure, which is the periopercular type, which is the most frequent type of polymicrogyria. Okay, again, these are pictures demonstrating the different forms of polymicrogyria, and again, this sign of the abnormal subarachnoid space overlying the cortex.
The prenatal diagnosis is difficult. I am showing this picture because this MR was performed in Israel and was considered normal at the moment that they performed the MR at 28 weeks. And this perhaps shows you that it's better if you need to perform an MR suspecting a malformation of cortical development that is not demonstrated in the ultrasound. It will be better to perform the MR a little bit later or not at 28 weeks. And the MR was considered normal. And this is the postnatal MR showing the bilateral frontal polymicrogyria that is very severe, and it's difficult to explain why it was not demonstrated by the prenatal ultrasound. It depends on the time of performance of the ultrasound.
It's important because polymicrogyria can develop at different phases of pregnancy, and now we know even after pregnancy. So sometimes you can have a normal ultrasound until the day of delivery, but we know that insults to the developing brain even after pregnancy, like CMV infection or like ischemia, can cause polymicrogyria that develops late. And we have different forms of polymicrogyria, and that's probably the explanation that it's not a mistake of the MRI, but rather it didn't develop yet. So we will now show a little bit about schizencephaly. So schizencephaly are clefts.
Okay, this is a severe case that should be diagnosed. The problem with schizencephaly is it turns out that there are no case reports of schizencephaly diagnosed before 20 weeks. There are 3 cases in the world literature between 21 and 20 weeks, and almost all the cases are diagnosed during the 3rd trimester. The chances to diagnose depend on the severity of the schizencephaly. If it is an open lip, bilateral, like in these cases, most probably we'll be able to diagnose by ultrasound. But it's a closed lip schizencephaly, unilateral, and the unilateral side is in the proximal side when you perform the transabdominal ultrasound, most probably you will not be able to diagnose these cases.
The most important hint for diagnosis of schizencephaly is that almost in 100% of cases, there's no septum pellucidum. So this is very important. When you see no development of the cavum septum pellucidum, look for schizencephaly. Okay, so we'll continue with other PMG, with other malformations.
Again, here you have a case that turned out to be polymicrogyria, but we saw in the same patient a lot of pathologies. The corpus callosum was not well demonstrated. There was ventriculomegalia. There was irregular ventricular wall. Also periventricular pseudocysts. A lot of abnormalities, and a lot of time it's very difficult for us to try to reach an etiologic diagnosis. Okay, the MR thing at this step it was also perhaps schizencephaly. The lateral ventricles were dilated. Okay, and the patients opted. You see, you have the MR. They saw that here perhaps there is perhaps schizencephalia. A lot of different things that were very difficult to put it inside one single diagnosis. And at 35 weeks, the patient decided to go for abortion. And we have a very good pathologist. And our pathologist found also cortical dysplasia, also subcortical heterotopia, also polymicrogyria, also the cerebellum was affected, and they found also extra CNS malformations. And when we published our series, we wrote that eventually when you perform ultrasound, prenatal ultrasound, you made the diagnosis of a malformation of cortical development, you send it to the pathologist, in a lot of cases, all the pathologies are in one. The same fetus have all. It was very difficult for us to explain why it happened because, you know, you hear about the classifications of Barkovich and Dobbins. They are very strict. It's that or that or that. But we found all the malformations together. So we wrote that. We wrote that perhaps our cases are the severe spectrum or something like that. It was not clear. And recently, in 2011, the group from Boston, they wrote that what the sort of cortical development tell us about the cortex. 1 + 1 doesn't always make 2. And they explained that perhaps one gene produces more than one malformation, or two genes produce different malformations. So it's not very clear until now which gene produces what. And this is particularly correct regarding the Strogrican, the cobblestone malformations, where there we have shown you there are a lot of different genes producing different disease. Thank you very much.